thanks for everyone for joining. Hopefully some more will join as we move along. So I'm just welcoming Dr. Victoria Landry, who is one of our integrated family medicine, emergency medicine residents. And Victoria is going to be presenting Journal Club today on the Britchko paper, Rapid Administration of Methoxyflurane to Patients in the Emergency Department, the RAMPed study. So this is a randomized controlled trial of methoxyflurane versus standard care and was published in Academic Emergency Medicine last year. We were hoping that Liam Walsh would be joining us for some pharmacy advice, but unfortunately he's got two kids have both gone down sick, so he's needed at home for that. And but he has provided some useful information that I'm sure Victoria's included in her presentation. So off we go then.
All right, thanks, Dr. Lewis. So I apologize if you hear my little toddler in the background. I have my big earphones on, so hopefully I won't get distracted, but hopefully it doesn't make too much noise. So like Dr. Lewis said, this is the paper we did. It's called the RAMPed study. There we go. So in terms of background, I guess what we'll do tonight is just kind of go through the paper first, and then we'll have some discussion. And then I'll talk about what Liam passed on to us, and then we'll talk about the critical appraisal as well. So in terms of the background of the paper, we know that timely and effective pain management is an important indicator of quality of patient care in the ED. And oligoanalgesia is common in the emergency department, which leads to reduced patient satisfaction and outcomes and potentially prolonged length of stay as well. And some of the barriers they listed were limited resources, overcrowding, and heterogeneity in prescribing practices, as well as with nursing shortages, delays to IV. And then they also talked about legislative requirements related to opioids as well. They cite previous papers which seem to conclude that the average median time to analgesia in the emergency department is 40 to 70 minutes. And they make note that there is an increasing attention focused on novel strategies to deliver analgesia in patient care at triage. So just before we really dive in, I just wanted to kind of introduce you to this medication. It's called Penthrox. The trade name is Methoxyflurane. So this just kind of gives you an idea of what this is. Hopefully this will play and hopefully everybody can hear that. Okay.
We can't hear it, Victoria, so you might want to just give a bit of a voiceover yourself.
Yeah, so basically there's like that little vial. They open it with the bottom of the pen, and then they put it into the bottom, and you'll see them swirl it around to wet the wick there. And then on the top, you can kind of see a charcoal chamber that helps to reduce the occupational exposure of the exhaled gas as well. And then it has a nice handy dandy thing to put around the patient's wrist as well. So that's all that's showing. So that's what we're dealing with. It is a non-narcotic inhalational fluorinated hydrocarbon analgesic. And it's portable, handheld. Patient can administer it themselves by breathing in on that whistle. It's 3 milliliters of the methoxyflurane liquid. And like I said, there's a charcoal chamber to reduce occupational exposures. It provides rapid short-term analgesia. So onset of action is 5 minutes, and it lasts for 25 to 30 minutes with continuous inhalation, or about an hour if you're intermittently inhaling it. And it's been used in Australia for the past 40 years quite widely, especially in the pre-hospital settings. And it's also used in over 30 countries across the world, mainly in Europe as well. And there's lots of studies demonstrating its safety profile. High dose is associated with nephrotoxicity, so there is an advised max dose of 6 mils a day and 15 mils a week, and it's not recommended to be administered on consecutive days. And with that small dose of 3 mils, there is no significant hepatotoxicity or nephrotoxicity documented. In the literature, mostly what they're looking at regarding methoxyflurane is use in adults with moderate to severe traumatic pain. And it's shown to have high treatment satisfaction among patients and clinicians. And there's no published reports of addiction or abuse. The objective of this study is to evaluate the effectiveness of methoxyflurane versus standard care for the initial management of severe pain among adult emergency department patients. And the way they did the study, it's a randomized parallel group open label phase 4 trial. It was done in Australia, in Melbourne, Australia, in an adult tertiary hospital that services 70,000 ED patients a year. And so the patients were screened at ED arrival by a trained on-site research assistant who was located beside the triage nurse. And this research assistant was there 7 days a week with variable times of the day, just based on their availability. And inclusion criteria included all adults ages 18 to 75 years old. And they did have to have severe pain. So their numerical rating scale pain score had to be 8 or above. And the exclusion criteria were largely based on the contraindications to methoxyflurane. Sorry, I'm just trying to get rid of that. There we go. And they also included those with intra-hospital transfers, those with hemodynamic instability. So they excluded people with a heart rate less than 40 or over 140 beats per minute, those with possible ACS, those with headaches, those who are pregnant, breastfeeding, those with known renal failure or liver failure, those with history of malignant hyperthermia or hypersensitivity to fluorinated anesthetic, and those who were aggressive or agitated in the emergency department. And just in terms of hemodynamic instability, they also excluded those with a rest rate under 6 or over 36, and those with a GCS less than 15. So I should mention there was a waiver of informed consent granted by the ethics board because it was impractical to gain consent while the patient was in severe pain, but the patients were given the option to decline being in the study. So the primary outcome that we were looking at was the proportion of patients achieving clinically substantial pain reduction, which was defined as a 50% drop in the pain score at 30 minutes. And then secondary outcomes included median pain score at multiple time points, 15, 30, 60, and 90 minutes, and proportion of patients achieving a more than 2-point reduction on the numerical rating scale, as well as proportion of patients requiring opioids. And then they also looked at adverse events from the methoxyflurane. So minor events such as nausea, dry mouth, amnesia, headache, dizziness, hypertension, rash, and sedation. And then more serious adverse events such as life-threatening reactions resulting in death, prolonged inpatient stay, or if it led to a known congenital anomaly. Data collection was done by a research assistant who was the one who enrolled the patients as well. So that research assistant gained information about the pain scores and the location of the pain, the discharge diagnosis and adverse reactions. Then the EMR emergency medicine record charts were reviewed for what analgesia they got and what times they received it. And then medical records were also looked at for the triage score, mode of arrival, and the length of stay in the emergency department. The analysis consisted, it was an intention to treat analysis, and they used a Fisher's exact test to look at differences in proportion of patients achieving the substantial reduction in pain. They used hazard ratios and 95% confidence intervals to look at the median pain scores, so the differences between times to those pain scores, and then the Wilcoxon rank sum test to look at differences between medians. They also looked at percentage of patients with more than 2-point reduction on the numerical rating scale for pain, and the percentage of patients requiring opioids. In terms of power, so the proportion of eligible patients achieving substantial pain reduction at 30 minutes with standard care was estimated to be 0.2. And 53 patients were required in each arm to achieve a minimum clinical significant difference to a proportion of significant analgesia of 0.5 of the population, using those 95% confidence intervals and 90% chance of detecting difference. A p-value of less than 0.05 was defined as clinically significant. So in terms of results, you can see here, just trying to figure out how to minimize there. I can now see my full slide. So they assessed 223 patients for eligibility. The exclusion criteria were applied, and that left 121. 61 were allocated to standard therapy and 60 to the methoxyflurane group. One in the standard therapy group had missing data, but otherwise all the patients were kept in the study. And the data was collected from September 4th, 2019 to January 16th, 2020. In terms of the demographics, the mean age was 42-ish years, 51% were female. 84%, the majority, were enrolled from 7 a.m. to 6 p.m. and most arrived by private transport, so only 4% came by ambulance. And then in terms of length of stay, in the methoxyflurane group, it was 180 minutes and standard therapy was 174 minutes with a p-value of 0.83. And you can kind of see there what the initial pain scores were, as well as the location of pain and the types of pain there as well. In terms of the primary outcome, it's highlighted in red there. So 5% of the standard therapy group and 10% of the methoxyflurane group achieved a greater than 50% reduction in their pain scores at 30 minutes. So it was a non-significant primary outcome with a p-value of 0.49. And highlighted in orange are the secondary outcomes. So you can see that more methoxyflurane patients reported a more than 2-point drop on the NRS scale at all time points. So at 15 minutes, 30 minutes, and 60 minutes, there was a clinically significant greater reduction in pain with the methoxyflurane group. And then you can also see that there's lower median pain scores at all time points in the methoxyflurane group. If you look down further here, another secondary outcome they looked at was the proportion of patients requiring opioid analgesia. So there was no, except for the parenteral opioids, there was no clinically significant differences between the two groups there. You can see that the time to methoxyflurane administration was 11 minutes on average. And interestingly, the time to rescue non-inhalational analgesia, which I'm not sure if I mentioned, but all the patients after receiving their initial pain management at any point could ask for additional pain management. So the time to additional pain management was longer in the methoxyflurane group than in the standard therapy group. So in terms of adverse events as a secondary outcome, there were no serious adverse effects with the methoxyflurane. 2 patients had mild dizziness with methoxyflurane and 2 had mild nausea, which this is consistent with literature already, where we know that low dose methoxyflurane is associated with transient mild side effects. And these do rapidly resolve after cessation. So in the paper discussion, we now see that methoxyflurane did not achieve the primary outcome of 50% reduction in pain scores compared to standard analgesia care, but they did achieve a lower median pain score in the first 90 minutes of emergency department care overall in the Penthrox or methoxyflurane group. And they note that so they selected only patients with severe pain. So this may have contributed to the low proportion of patients achieving the primary outcome. In another study that was done on methoxyflurane, it showed that the most significant reduction in pain was achieved in the first 10 minutes after methoxyflurane administration. But in this study, it was showing consistent, it was kind of across the 90-minute time span that they had reduced pain. And this is potentially because there were less opioids used in the standard arm, because trauma and hemodynamic instability were excluded. And so, as I said, they had a moderate to severe, patients still did have moderate to severe pain at 90 minutes in both groups. In previous studies, the population was restricted to those with traumatic etiology. So this study adds to the literature in that we can see that methoxyflurane does have benefit in a large spectrum of conditions, not just traumatic etiologies. And in this study, almost 70% of patients did not have preceding trauma. And they cite that in previous studies, they mainly looked at traumatic pain because methoxyflurane is currently only being licensed in Europe for use in conscious patients with pain due to trauma. They did a really good job of outlining the limitations of this study. So they talk about how it's open label, so it was not blinded, simply because it's difficult to, the Penthrox whistle that they use has a distinct smell, and also the patient knows that they're using that whistle, so it was difficult to blind for that reason. There was a wide variation in types of analgesia used, and in the median time to non-inhalational analgesia. It did vary between the two groups. And interestingly, in the methods section, they talk about collecting the types and timing of pre-hospital analgesia prior to ED arrival. But they don't actually talk about this outcome because it wasn't actually collected. And the study did not include a cost analysis either. They talk about the sample size was determined according to a power of 0.9 and with a low proportion of patients achieving substantial pain relief. So this may have overestimated the feasibility of achieving this magnitude of pain relief. And so there might have been a reduced power in this study. In the methoxyflurane group, they had a higher proportion of high triage category. You can see that highlighted in blue there. There's 12 versus 6 as a triage level 2. And so that could translate to sooner analgesia. But if we accounted for this difference, it would further strengthen the conclusion that there was no difference in primary outcome. And 25% of total patients had a score of 4, a triage score of 4, which could lead to delays in analgesia, which could account for the overall not huge reduction in pain scores. And they just mentioned that further trials could stratify by triage categories to account for that confounder. So in conclusion, as we've talked about, initial management with inhaled methoxyflurane in the emergency department did not improve the proportion of patients with a greater than 50% reduction in pain scores. However, it did improve pain scores with a lower median pain score at all time points up to 90 minutes. It was not associated with serious adverse events, and there was no significant change in opioid use between standard therapy versus methoxyflurane. So I'd like to just open up discussion at this point to hear what people's initial thoughts are, and if anybody has put any thought into, is there a role for this in our emergency department? And if so, what are your thoughts around how it could be implemented, if at all?
Great. Thanks very much, Victoria. Maybe before we open it up to the group, I just wanted to just explain why I chose this paper. I had observed, and I think we've all seen, like increasing wait times in our department, and particularly with the shortage of nurses, there are patients that come through triage. They might get some Tylenol or Advil, and then they may sit there for hours on end, and there's no one really to check on them and to re-analgesize them. And I saw this paper reported, and I thought, this might be something that may be of benefit to us in terms of, it doesn't require the same nursing resource to analgesize a patient with this. This is a self-directed medication. So I personally haven't used this. I'm not sure if anyone on the call has seen this used. I worked in Australia myself for several years, and we didn't use it in the department that I worked at.
I've used it a lot.
Where did you use it, Rachel?
We used it in Exeter and a bit in Plymouth as well. And I have to say, I think it's a good alternative for those patients in the corridor who you know, in an ideal world, you'd get them into room 10 and you give them some IV opiates and put their shoulder back in, and that's the best pain relief for them. But if in reality they can't have that and they're going to be sat in a corridor for 2 hours, this is great. And it's not going to take their pain away in the same way as an opiate would, but it's better than doing nothing for them, which is what we kind of currently do.
Does anyone else have any observations on the paper on the potential for use of this?
David, I think they're
Any
using this
question?
in Halifax. Sam Campbell, I think just they, in their department, rolled it out. They were using it for, like Victoria said, traumatic injuries. And the stuff they've collected so far is more, I would say, case series. They were trying to get ethics approval to look at something a little bit more robust, but I think their experience with it was somewhat reassuring in the sense that for practical reasons, that increasing wait times, patients with severe pain, that the benefit that is just exactly like you say, drop that few mils in there. So, you know, if we are interested, we can certainly reach out to them to say what's their experience been practically. And then James, I think everyone saw his message. Suppose they're using it in the company that he works for.
Right.
I was a participant in the study that Sam and them published, and it was using Penthrox specifically for the anterior shoulder dislocation. And I think the context that it's, you know, the utility is kind of most relevant for is like when we're doing a procedural sedation and we do it with our department medics and the department's kind of on fire and those resources aren't available at the time. There's definitely, seemingly, at least on the basis of the abstract that they published, a utility for it. Yeah, and it was successful. I was only there for just one reduction using Penthrox, and it seemed to work great anecdotally.
Do you have do they have nitrous oxide in Halifax?
I haven't seen it used there before.
Right. Yeah, I mean, what's the advantage of nitrous oxide over Penthrox, Victoria?
So I think it's the less risk of malignant hyperthermia. So they were talking about how if it's a fluorinated anesthetic, and if you have sensitivity to it, then you can't use this. But nitrous oxide isn't a fluorinated anesthetic, so you can use it safely even if you have had a reaction to a fluorinated anesthetic.
Yeah. So I mean, that's one of the things that, I mean, even though they do report, don't they, that throughout the entire literature of, what is it, 40 years use, there's only been one case of malignant hypothermia using Penthrox. I think that's probably because of the low dose, but it is still a potential sort of risk, I guess. And, you know, it's certainly something that they recommend not using in patients with that history. So it involves, you know, asking them, do you have a history of anesthetic related side effects, I guess, or malignant hypothermia, which, you know, nitrous doesn't. I mean, nitrous also, you know, the way that we deliver it, you know, renders them, it does actually alter the level of consciousness a little bit. You might drop 1 point on your GCS just for sort of disorientation, whereas this doesn't do that. You know, the amount of analgesic effect, and I don't think they did actually. I'm not sure if it was in this paper or somewhere else I read. There was a question as to, you know, maybe they should have compared, or another study would be to compare this to nitrous oxide. Obviously, the advantage of this over nitrous oxide is that, you know, this is self-administered. It can be done sort of in the waiting room. You can't really give a patient, although nitrous oxide is self-administered, it's generally recommended that someone is, you know, reasonably close by to provide that kind of assistance, because if you puff on it long enough, you'll drop the inhalator.
I've never used this before, but I've used fentanyl lollipops in the field on multiple occasions, and patient-controlled analgesia, particularly in situations where there's multiple competing priorities, is very humane and it works great. The fentanyl lollipops just provided breathing time, the patient analgesia, and you could prepare for definitive treatment. So I think something like this would be great in the department.
Is anyone aware of fentanyl lollipops being dished out in any emergency departments, triage?
Oh, I don't mean for fentanyl lollipops. I mean something like this. Fentanyl lollipops are, I don't even think they're licensed in Canada. They're
Okay.
Surgeon General item.
We had them in Emerge in one department I worked in. I don't think we put people back in the waiting room with them, but we certainly used them in the department.
Yeah, I think I can think of a portion of our clientele who might be asking for fentanyl lollipops while they're waiting to be seen, but
And then they'll mug all the old ladies with the fentanyl lollipops whilst in the waiting room.
yeah. But I mean, I think your point's well taken there, Chris, that it's not so much the agent, it's the fact it's patient controlled. That is that's a humane way of doing it. I mean, this is something that the anesthesiology have sort of brought in over the years on the floor, patient controlled analgesic devices. Usually they control the IV, which has a limiter set on it, and I think really in our current situation of we need to look at any kind of innovation that does reduce the need for nurse intervention. Anything we can do to improve the care of patients and reduce the workload on nursing, I think, is going to be beneficial. Did you mentioned the cost analysis? What were your thoughts on that, Victoria? In terms of, did you get any information on how much this cost?
Yeah, so it costs, so Liam helped us out. Maybe I'll go to that slide here. So a word from our friendly neighborhood pharmacist. So he looked into this for us, and according to him, and I don't know if maybe Dave knows if it's currently being used in Halifax, but he was saying it's no longer available in Canada since January because Purdue was the manufacturer, but they transferred the manufacturing to Paladin Labs and they haven't started selling it yet. But so it could be available down the line again, and it likely will. And he was saying it costs $45 for one whistle. So yeah, and then just on this slide here, Liam was saying that the way medications are introduced in our AD is you can ask for a trial period for them. And then if we find that we like it, then we can submit for a formal request to add it to the formulary. And he was just saying perhaps the evidence isn't like super compelling to add this to the formulary, but he has seen less compelling medications added. So that's our word from Liam.
I don't know if it's a licensing thing or just a recommendation, but my understanding is it's licensed just for like traumatic things, whereas you wouldn't use it for a renal colic, for example. Whereas a fentanyl lolly, obviously you can use it for anything. And I think if you were sat in the corridor with a neck of femur fracture or renal colic or something, you probably could be more comfortable with a fentanyl lolly than one of those. And certainly it's not licensed for abdo pain and stuff.
Yeah, I think Chris was saying fentanyl lollies aren't available in Canada.
Yeah, my understanding is that they're not licensed here. They're the military gets them as a Surgeon General item.
Yeah, so I think it's either that it's we don't have the option of the fentanyl lolly, so this would be the alternative unless there's any other kind of option that would be an equivalent to this or a fentanyl lolly. I guess we could always make our own. Like drop some fentanyl into one of those popsicles and
set it up in your basement, David. We'll start cooking it down there.
Did anyone have any other thoughts on the paper itself in terms of the way the study was conducted? Any issues with the methodology or the presentation of results? I had one other question, Victoria, just on the on some of the exclusion criteria. There was the the fact that they excluded patients with a pain score of, I think it was less than 8, wasn't it?
Yes, that's right. It was 8 or they had to have a pain score 8 or above.
Yeah, I mean, that's, to me, that seems like quite a high pain score. Yeah. You know, do you think that, I mean, firstly, why would they have done that? And secondly, do you think that might have impacted the study results?
I think so. And they talked about, I'm not sure if it was in the limitations of the discussion, but they talked about how that is one reason why their primary outcome of a 50% reduction in pain may not have been reached, just because of the severity of the initial pain. In terms of why they did it, I'm trying to remember if they addressed that in the paper. I'm not sure. I think potentially because that's the patient demographic we really want to help. Like if they have severe pain, we want to be able to reduce that pain as quickly as possible. Whereas if they had a lower pain score, perhaps Advil and Tylenol are just adequate, and we don't need to look into, you know, something more potent. But I'm not sure if anybody else has any other thoughts on that.
I mean, the other thing that I noticed was that that probably affected the power calculation. If you look, I think they said that was going, they were looking for a power of reduction of 20%, weren't they? I think 0.2, I think they said. That's how they powered it. They expected it. They expected standard analgesia to reduce the pain score. Where have you got the power there? I think it was 0.2. Yeah, so reduction at 30 minutes estimated to be 0.2, so 20%. Whereas in reality, it was only 0.05. So it took I think it was 5% reduction, wasn't it? Rather than the 50% reduction for the standard. So I think that's kind of the one of the errors that they made in this study from the power point of view, is they significantly overestimated the effectiveness of both standard analgesia and the methoxyflurane. So that, you know, that was an issue there. But whether they took that from another paper, they don't really explain how they generated that power calculation. You know, sometimes if you're the first person to do a study, you have to kind of just make it up. Isn't that right, Kavish? For power calculations, or is there an accepted way of generating a power calculation if there's no previous research?
If there's no previous research, I think you have to decide what would be clinically relevant. And to me, it seems like they went, which is maybe the strength, even though it was a negative study, they certainly went above and beyond, I think, what most of us would have said would have been a reasonable reduction in pain.
Yeah.
I mean, we've reviewed a number of different pain studies, and I think at best the sort of industry average is a reduction, like on a scale from 1 to 10, a reduction by 3 points is considered like really, really nice. So I'm almost curious if they had calculated their power based on that type of reduction, would the outcome have been different? But I think it's nice to see that they went above and beyond to try to knock it out of the park, so to speak.
Yeah. One of the other things I noticed was that the proportion of patients in the study didn't include many EMS patients. Most of them were had self-presented. Did you have any thoughts on that, Victoria? Why, if you look at the transport by ambulance, it's like 5%.
Yeah, and I think that might be because in the exclusion criteria, there was hemodynamic instability. And so those arriving by ambulance might be more likely to be hemodynamically unstable and therefore excluded potentially.
Yeah. I mean, the other thing that I was thinking was maybe if they're in an ambulance, they might have already received analgesia, and their pain score might actually be less than 8 after that transfer and and the analgesia from paramedics, because I believe in Australia they have access to quite a bit of analgesia via EMS. I think they're allowed. They have like orders to give opiates, etc. there.
One sort of nitpicky thing that I noticed in the exclusion criteria was that they excluded those with headache, which isn't a contraindication as far as I could find to methoxyflurane. So I'm not sure if those with more experience with this medication know why that might be, but it was just an interesting exclusion.
Yeah, I'm not sure why they excluded headaches. I mean, one of the things that I was kind of postulating was that maybe they were at risk of reduced level of consciousness. You know, if the cause of the headache was head injury. I think later on in the paper they say headache, stroke, head injury, don't they? It's almost as if they're kind of, you know, grouping those two together as a single entity. You know, you could understand why they might want to exclude head injury, and I guess, you know, if they're concerned that a patient has subarachnoid or meningitis or something like that, then, you know, that might be a reasonable patient to exclude. And also those patients might be given a higher triage category and maybe even moved through, you know, more urgently. And I presume that's why they excluded the hemodynamic instability patients. You know, again, the same if they've got, I think the blood pressure they mentioned was over 180, wasn't it, rather than 140, I think you said. And, you know, that to me is like, just these patients are going straight through to a monitored bed. You know, so therefore we're going to exclude those because, you know, then they're not ones waiting in the waiting room. Okay, did you want to go through unless anyone else has any other comments, did you want to go through the appraisal part?
Yeah, feel free to interrupt anybody, but so in terms of critical appraisal, just answering the questions for critical appraisal here. So the assignment of patients to treatment groups was truly randomized, and I think I might have skipped a slide earlier, but they were randomized with a computer generated randomization without stratification. And then they were randomized 1-to-1 as the patients came through triage to the methoxyflurane or the standard analgesia arm. So they were randomized, and they were all accounted for. We went through that table earlier, the figure earlier, and we discussed there wasn't blinding just because it wasn't feasible with this intervention. I suppose they could have used nitrous oxide as the alternative, but they chose not to here. And similarity between groups was documented, and we discussed the minor deviations in that. The groups, I presume, were treated the same way there, aside from the intervention as well. And we discussed the results already, so how the primary outcome was non-significant. And these probably can be applied to our population. In general, if you look at the initial demographic table, and we talked about most were about 42 years old, so about middle-aged, triage score 3, and most of them did have like a pain in their upper or lower limb, so an injury. So, and we see all sorts of patients in the ER, so certainly this can be applied. And I think all clinically important outcomes were reported. We already discussed how cost analysis wasn't a part of this study. That would have been a kind of a separate analysis. But other than that, everything that I could, so adverse effects, time to administration, pain scores, and opioid requirements were all documented. And in terms of benefits versus harms, certainly there weren't significant adverse effects with this intervention, and it did decrease their pain scores. So I said yes for that as well. And so in conclusion, the results are valid and clinically important, and I think they are relevant to our practice as well. So I think that's all I had to say about the critical appraisal. I'm not sure if anybody else had thoughts about that.
Any other thoughts at all? So I'm just putting a vote here. So if you just, so based on this, on the discussion today, this paper here, imagine we have, we've got it's extremely busy in our department. The waiting room's full. We have access to the methoxyflurane. This is something that you would prescribe to a patient with a broken arm who's sitting in the waiting room and may have to be there for a few hours. You can post it in the chat if you want. Okay, so if it thumbs up, and I mean that's my kind of impression from, I think this was actually a really well designed study, other than probably the power calculation, but as Kavish has pointed out, it was it was better to be overpowered than underpowered, so to speak, at the outset in terms of their calculation. And the design of the study was otherwise, I thought, very good. I thought it was well written. It would be interesting to repeat a study like that here, but maybe they've already beaten us to that in Halifax. I didn't. So where did they publish that abstract, Dave?
I thought it was in CGEM. I'm not sure.
Okay, so do you have anything else to add to that, Victoria?
No, I don't think so. It certainly seems like an interesting treatment, and it always is interesting to me how different parts of the world use different things, just, for various reasons. So it's nice to go through this and to see what alternatives there are.
Next time we'll do one on IV Tylenol. That's something I would love to see here. Apparently it's too expensive. I can't imagine why it's expensive, but anyway.
Yeah, thanks for suggesting this paper. I learned a lot. Looks
Thanks,
like
Dave.
Thanks, Dave.
Yeah.
We should call it IV paracetamol so people don't catch on. It's just Tylenol in a different form.
yeah. Okay, well, thanks for joining us, everyone. And thanks very much, Victoria. That was a great job, and really excellent review of that paper. So thanks very much.